morning. I'm going to talk you through three areas that I've been asked to cover this morning. So, the first is around, is NHS 111 making it easier for patients to access urgent health care? The second looks at the clinical expertise that sits behind it. And the third touches on partnership working and the importance, because none of what I'm going to talk about this morning is possible unless we work together. And we've heard the word integrated used twice, I think, in the presentations this morning. This is part of an initiative to actually develop a 24/7 integrated emergency and urgent care health system. And to enable us to do that, it's about that partnership working. So, NHS 111, it's a joint initiative between the Department of Health and the NHS. It's part of those wider revisions that I've just touched upon. It's developed and implemented to help access to urgent care, and it's urgent care defined by the user, the person at the end of the phone, who needs help now. It is about right service, right time, as much as we can possibly get it. It is challenging and thought-provoking, and I think I've been called controversial. I'm quite proud of that, really. And it is probably one of the biggest changes that we've tried to introduce in this country, and I've been told, across the world. So it's not an easy thing to do. We've got a clear policy in terms of telephone access. 999 if it's an immediate life-threatening emergency, your own GP number if you need help, and 111, which provides you, if you need medical help fast, but it's not a 999 emergency, you don't know who to call for medical help, or you don't have a GP, and there are many people in this country who don't, you think you need to go to A&E or another NHS service, but you're not quite sure, or you require health information. And set against that context is the understanding that the 0845 number that's operated by NHS Direct will cease next year. So this is about getting people to the right service, right time when they don't know where to go. And it's very common. It's happened to me. It's happened to me when my husband was taken ill. Trying to find the right route in is quite difficult. And why? Because we've created this, all for the right reasons. So we've got walk-in centres, Miamis, which are minor injuries and minor illness units. We've got urgent care centres. We've got all sorts of services that we've set up in primary care to try and help improve people's health. But we've created quite a nightmare in terms of navigation through this system. I wanted to sort of set the context of where we were, because I've been working on this now since 2007, 2008, where I worked with a group of clinicians within the East Midlands, as did other regions around this country, to try and prioritise what it is we should be focusing on. And access to urgent care was something that clinicians said, we have got to crack this. We've got to try and create something that improves on the situation that we've got at the moment. So the list I have here sort of outlines that. Lots of different names, functions, opening times of services, lots of different triage and clinical assessment systems that sit underneath those, whether you ring in through the ambulance service, NHS Direct, through out-of-hours services. Limited recognition of the services and the skills that we've got out there actually in the community. We've got a wealth of talent, but actually trying to understand, if you're a paramedic, you've reached somebody, you've gone out to their home to treat them, but actually you know that patient doesn't need to go into hospital, but where else can you take them? You start to get to understand that actually if we could improve that system, then we can make huge roads into improving patient care and reducing the finances that we have to put into sending expensive ambulances or people attending A&E. So we set about designing a service. So these are the core principles. When you hear about service specifications, this is the core principles that underlie a national service specification. What sits underneath this at a local level is how you localise it. But if you're going to have a service that enables access, you've got to have some upfront principles, and these are the list. So easy to remember, it got to be comparable to 999. And 111 was chosen because there were only 15 numbers available to us, and 111 was the only one that had got 3 numbers the same. It's also top left on your mobile. Don't look at them now, look at me. But that enables you, if you've got poor sight or visual impairment, to find that number. We also wanted to have some consistency, obviously, of clinical assessment and be able to pass that information to the right people. We wanted to be able to offer this service 24/7, and it's got to be the cornerstone of this 24/7 service. And the other principle that was absolutely vital was if people phone the service and it is a 999 emergency, then we should be able to dispatch an ambulance without delay. So it's not about talking to somebody and saying, okay, put the phone down, dial 999, or a warm transfer through to another service to get you to 999. It's about being able to pass that electronic message, hold the call, and see that ambulance get to the patient without any retriage. And that's a major step, both for the NHS and the ambulance services that work within it. So yes, you could say I'm crackers, and I do like pushing boulders up hills, but so do a lot of other colleagues that work in the NHS, and this is what we've achieved so far. So we've got the national telephony in place, and that's no small deal. We've got that easy to remember number. We have now got a consistent approach to telephone assessment. We have the ability to dispatch those ambulances and the trust of the ambulance services and faith to do that. We don't have handoffs or ringbacks. They're not the norm. Where they do happen, they're absolute minimum, and we try and cut them out and reduce them as much as possible. We have introduced, at the moment, longer, more structured questioning, and that is a change for patients who do ring on the number. To be able to get that patient to the right place, right time, we do need to ask more questions, but they are clinically appropriate questions. We do have satisfied staff who don't have the angry client on the end of the phone, because we're able to handle the call in one go, and it has created job opportunities for staff. And it is improving access to community-based services. So I haven't read the whole list out, but you can see there's been a whole shift in that period of time. So where we are now is that we are rolling out the system, and we're starting to embed the system. We've got pilot sites in various parts of the country, and I'll show you in a minute in terms of where those sites are. Some have been operating over a year, some are only just, as in Croydon and Hillingdon, have come on stream fairly recently. North Derbyshire has come on stream in October last year, and we'll be moving to other parts of London and Oxfordshire in the next few months. We've put in place a superb clinical governance structure which actually brings the key players in this really important business round the table. And even if 111 stopped now, the fact that we've got those people round the table discussing emergency and urgent care and where patients might fall through the gaps between different service handoffs, that to me has improved the urgent emergency care system beyond anything that we had before. So we've got the ambulance service round the table, we've got the out-of-hours services round the table, we've got NHS Direct, we've got social care. We can actually start to hear and listen to calls and understand what's actually happening to the caller. And where we perhaps could have done things in a better way, we can put things in place very quickly to improve things. So this is a rapid response and learning service. This is where we are at the moment. We have to have whole coverage of the service across the whole of England by March 2013. There are discussions underway as to whether that that timeline should be extended slightly to allow for, obviously, the huge changes that are happening in the NHS at the moment, and for clinical commissioning groups to get to grips with what opportunities lie beyond the number. Because if we only focus on the number, we will absolutely have missed the point. I don't expect you to read all of these, but the ones in green are where we're live at the moment, and the list, and I'm sure these slides will be available later, give you the timelines where different areas of the country are either procuring the service, that means they're out to tender, they've decided to pilot it first and then procure later, or they've taken the opportunity of an opt-in, a safety net, before they finally procure it. So yes, we're still pushing the boulder up the hill, and there's still a lot of those crackers to carry. How the service works. Call comes in at the top. A call handling service will take that call. At the moment, we're testing it out with call handlers that have been retrained within ambulance services, within NHS Direct, within out-of-hours providers. You've got direct access to health information if you want it. If there is self-care advice needed, we can provide that. If it's assessed immediately as a 999 electronic message sent straight to the ambulance service. And if not, we can now search an electronic skills-based directory which matches the needs of the patient with the skills available at the time in the community. So a real shift and change. Are patients getting better access? The interim report says yes, they are getting better access. Just a quote from one patient and a caller in Lincolnshire and what happened to them. Somebody who may well have turned up in A&E, have had to wait a long time, but with this service got to the right place for the right treatment, right time. And in the North East, Chief Executive of the ambulance service there who are now providing this service has said it's saved many lives, and this is just one of them. Expert clinical advice. The NHS, the department has not mandated a clinical assessment system, but the NHS has chosen to use a system called NHS Pathways, developed by the NHS, by clinicians within it, to work within it to our clinical guidelines. Call handlers are supported by nurses or other clinicians. It could be a doctor, and it's usually on a ratio of 3 to 1. So the call handler handles those calls as far as they can possibly get them, potentially all the way to that ambulance dispatch, and that happens in many of the calls, and about a third of them may well be sent through for a nurse to ask further questions. I know doctors have been very concerned that if the disposition that's reached is it's a speak to or contact, that they've got to rigidly stick to that. We've listened and learnt and rephrased that, so there is an understanding that definitive clinical assessment always sits with the doctor at the end of the line, and if they can deal with that call more effectively on the phone when we've passed it to them, then that's totally appropriate. We've got that directory of services and the skills that are being delivered in place, and we're responsive to change. Again, we have, across the country where we are piloting this at the moment, groups of people get together, feed back their experience, and we move and shape and reform the service in light of those feedback, or that feedback. So, electronic directory of services could include social care, mental health, district night nursing services, thousands of services that exist out there. Commissioners decide what goes onto that directory. And it's more than accessing a service. It's all of these things. The importance of partnership working, we couldn't achieve this, as I said from the beginning, without partnership working being in place, and without people coming together to help shape and focus that, and that includes patients. This provides you with a sort of a glimpse into what happens at a local level and how much time and effort goes into getting this right. And evaluation and learning, it's constant. It's part of the process and what makes this so innovative and exciting to work with, and I'm really proud to be standing here and telling you about it. And if you want to find out more, this is where to get it. The website at the bottom, we're just loading it to provide public access to information about 111 so you can get more information direct from us. But thank you for listening.
Thank you, Chris, and I'm sure that everyone would agree that you and your team are right to be proud, to take pride in this project. Chris has reminded me that I should say to you that all the slides that you see today will be emailed to you, and also, and it's a bit late to tell my colleagues here, but all presentations will be posted on YouTube. So if you are a would-be presenter, bear that in mind in your comments and presentation. I want to ensure that we do get half an hour for coffee and networking, but if there are any brief questions, I know that Chris and colleagues here will all be around during the coffee break. You can speak to them, obviously, individually, but does anybody have any particular questions that they'd like to ask for Chris? I'll take a question here, question there, and the third one at the back. But if you could give me your name and organisation and be succinct, that would be helpful.
Councillor Malcolm Lawrence, Penzance Town Council. And so I speak XNA.
Oh, I'm sorry, I meant the gentleman behind you.
Oh.
I am going to disconnect you. With apologies.
Hi, I'm Phil Aubrey-Harris. I work for Southern Health, which is a large NHS provider in community services in the south of England. We're keen to work with our 111, prospective 111 and out-of-hours providers to look at how they integrate with our services. And one of the things I'm conscious of is that we want our known patients, particularly those that are high risk with anticipatory care plans, end-of-life plans, etc., are kind of, the 111 and out-of-hours service are very much aware of those, very close to the point that they're making those assessments. What are you thinking about nationally in terms of ensuring that patients that are known to services that are on things like end-of-life plans, etc., that those plans are taken into account within pathways, which is effectively a very rigid assessment?
Thank you. And the questioner in the middle there. Yes, thank you.
William Pickering from the Royal College of Psychiatrists, but I used to work for an ambulance trust. That's the contact there. The trust I used to work at was quite keen on the service being the gateway for the calls to 111. And I'd just like to clarify the involvement of the call takers in the ambulance service linked into 111 and how that fits in with the need for an ambulance or like an emergency care if it is an emergency.
Thank you very much. And right at the back. Who was it who I saw first? I can't see you. No, was it you? Which one? I don't know. That is a great question. That's a good answer.
If I'm
going to say it was you.
Thanks very much.
For that.
Very quick, you might get all four in. Neil Hughes, I'm from Cumbria Link. Now, as you demonstrated in your slide, Cumbria is the one area of the country certainly that you displayed who are pausing on going on to 111. Now, I'm not personally familiar with all the reasons that the Shadow Clinical Commissioning Group have not decided to opt for 111 at the moment, but they are concerned about the competence, I understand the competence of those answering the phone in terms of clinical ability. The fact that not all practices have to opt into participating in the system, and therefore there could be gaps. And perhaps most of all, and this affects us with all remotely delivered services, not just health services, whether the person answering the phone will understand the complex geography of our very rural mountainous county well enough to be able to assist the caller. So have some response.
Thank you very much. Chris.
Am I? Hello, can you hear me?
You are.
Good. Okay, 3 questions. I've left my glasses at the podium, so that's always wise, isn't it? Let me try and answer these questions. The first one's about the care plans. Absolutely important that we ensure care plans link into this service. I chair a group of all the SHA leads, and we ensure that where we've got areas like London at the moment who are building this into their service specification at a local level, that we are able to share that learning very quickly so that other areas can link in palliative care, end of life, long-term condition management plans into the 111 service specification. So absolutely key. Thank you. In terms of the call takers, and 999, many ambulance services are moving towards using NHS pathways as opposed to their current system, so that we've got the consistent clinical assessment under 999 as well as 111. You can see the benefits of that, because that would allow that paramedic on the ground to be able to access that directory of services and know where they could safely refer that patient onto. So there are some huge benefits here if we can get this right as a whole system, but it takes a huge amount of courage and faith to do this. But I have to say, people are grappling with this now, so I think there'll be good news on that front. And in terms of the call handlers and their expertise, the call handlers for this service, wherever they are and wherever the service is procured, are highly, highly trained, as they are in the ambulance service taking 999 calls. This will mean that they will deal with the vast majority of calls that don't need to go to services like out of hours unless they actually have to. And what that does is allows doctors working in the out of hours to provide the service and the high quality of service to the patients that do need to be seen or spoken to by a clinician in the out of hours period. Callers that can be dealt with at another time of day or can be helped through self-care or advice are dealt with that way, and that is the vast majority of calls that are coming through on the service at the moment.